Welcome. My name is Julie Steenhuisen, and I'm a health and science correspondent with Reuters news agency, and I'm your moderator for today. Our program is going to be an hour long, and it's a collaboration between the Forum at the Harvard T.H. Chan School of Public Health and Reuters, which is streaming today's event. Today's panelists, starting from my right, are Marcia Castro, who's an associate professor of demography at Harvard Chan School and a member of the Faculty Advisory Committee of the Brazil Studies Program. I'd also like to introduce Ashish Jha. He's the director of the Harvard Global Health Institute and a professor of international health at Harvard Chan School. And the Honorable Nils Dollaire, who is the former Assistant Secretary for Global Affairs in the U.S. Department of Health and Human Services. And joining us remotely is Dr. Anthony Fauci, who is Director of the National Institute for Allergy and Infectious Diseases. This program is going to include a brief question and answer period, and if you like, you can email questions to the forum at harvardhsph.harvard.edu. You can also participate in a live chat, and that's happening right now on the forum site. So I encourage you to do that if you'd like. We're here to discuss the spread of the Zika virus, which the World Health Organization has recently declared a global health emergency. This virus is no stranger. It's been around for decades, but recently it has begun spreading rapidly in South America, in Central America, in the Caribbean. And there are new concerns about links to a birth defect called microcephaly. And this has raised many alarms in Brazil and elsewhere. And adding to the worries about Zika is the new discovery that the virus is not only spread by mosquitoes, but it can be spread through sexual contact, and it also can be spread through blood transfusions. Let's take a look at a clip from Reuters. It was taken on February 24th, and it's about the CDC looking at possible cases of sexual transmission.
The CDC investigating 14 new cases in which the Zika virus was possibly spread through sex. Reuters health editor Michelle Gershberg.
The CDC statement has potentially global implications about the Zika virus. We're far from saying that we know for certain that sexual transmission is a possibility, but what it starts to do for public health officials is raise the awareness that, it's not just about tracking the mosquito. With a world of global travel, right, we could start to see Zika virus pop up in a more significant way in countries where you wouldn't necessarily expect the mosquitoes to arrive.
Health officials have been struggling to better understand the mosquito-borne Zika, which has been linked to brain defects among newborns in Brazil and has spread to more than 30 countries so far. The CDC's announcement Tuesday highlighting how little is still known about the virus. Billionaire Bill Gates, who says his powerful foundation is deeply involved in fighting the epidemic, telling Reuters much more needs to be done.
This one has definitely caught us by surprise. Zika was not recognized as causing a big problem. You'd like to say, okay, here's an outbreak, and literally within weeks have antibodies, diagnostics, drugs or vaccines against these things. We're not, the medical science is not there, and the orchestrating the resources quickly is not there.
One bright spot, 2 medical centers in Texas on Tuesday said they were rolling out the country's first rapid detection test for Zika, which provides results within hours rather than the days or weeks previous diagnostics needed to process. The test is currently only available to patients registered at the 2 hospitals, but researchers are planning to expand its availability to other facilities.
Thank you. And now I'd like to turn it over to Dr. Fauci. Dr. Fauci, can you tell us what is known about Zika? What are our concerns? What do we need to know? And how are we coping with this new virus?
Well, it's important to realize that this is an evolving situation. And as the weeks and months go by, we learn more and more. And I'm certain that there are going to be other things that we will be learning. So if you want to talk about the challenges that we have, a key challenge is to understand the disease as it is evolving before us. You mentioned very correctly that this is the first mosquito-borne infection that is apparently now, with more and more compelling evidence mounting, that there's a direct causal relationship with congenital abnormalities, particularly microcephaly, in children. You mentioned, again, the important aspect of its sexual transmission, because that has implications, as you say, for people who might go to the countries or the region involved and come back and have sex even with a non-pregnant person and inadvertently make them infected. But importantly, people who have pregnant wives or pregnant girlfriends, the recommendations from the CDC now evolve that. I think if you look at the recommendations from the federal government and other agencies, how they've evolved over the last few weeks is a testimony to how we're learning things. There's the recommending women don't travel because we know of now a very growing connection between infection during pregnancy. Then telling men who come back to practice safe sex or refrain from sex if you have a pregnant sexual partner through the duration of the pregnancy. Then we have the transfusion associated and now refraining from transfusion. I believe that we're going to be learning more and more. So we really have key challenges about that. Guillain-Barré, we just had a recent report from French Polynesia with an incidence of about 24 per 100,000. We need to know more about that. The other thing we absolutely need to know is the relationship between asymptomatic infection and symptomatic infection. Does an asymptomatic person who likely has a lower level of viremia, is there the same risk to the fetus? Is there the same risk to transmission? The other critical issue, you mentioned this idea about diagnostics. The question I get asked most of all is where women who are pregnant have been there but feel well. They want to know if they've been infected or not. And, you know, it's nice to say, well, do serial sonograms and ultrasounds, but they want to know now, have I been infected? And I think to be able to have a sensitive and specific antibody test is important. And then the other challenge is obviously the issue with vaccines. We need to get a vaccine, and we will soon, into early phase 1 trial to determine safety and whether or not it induces the kind of response you would hope would be protective. The good news about that is that Zika is a flavivirus, and we have made vaccines against flavivirus. Yellow fever, we've made vaccines against dengue, and we would have had a vaccine for West Nile if we had a company that was interested in partnering with us. So there's a challenge there, but it's going to take time. So right now the issue is going to be control it by mosquito control and by avoiding mosquitoes.
Thank you, Dr. Fauci. Marcia, you were recently in Brazil. Tell us what you've observed there.
So a lot has changed since I was in Brazil in January. And just to give you the latest numbers that we have as of February 27, there have been about 5,900 suspected cases reported in the country since last year. Of those, 641 have been confirmed for microcephaly, and of those, about 80 had a Zika virus confirmed in the baby. But we still have 4,200 cases that are under investigation. Most likely, a lot of those are false positives, sort of connected with the screening criteria for microcephaly that the government is using now. If you think about Zika virus, it's being transmitted now in 22 of the 27 states in Brazil. And although probably you've heard the figure of 1.5 million cases, we really have no idea how many cases we had because the disease was not of mandatory notification. This just changed February 18, so we don't know the numbers. In terms of the relationships between Zika and microcephaly, as Dr. Fauci said, we still have many questions that we don't have the answer for, but there certainly have been a lot of production of knowledge in the recent past. So we have several cases that have been reported showing the presence of the virus in the amniotic fluid, in the placenta, in the blood of the newborn, in different organs and tissues of fetus. But the connection or the causality has not been completely accepted or established. What is important is we had one case reported about a week ago of a woman that had a perfectly normal ultrasound by week 14 and starting on week 18, abnormal ultrasounds. Week 32, fetal death. What is curious about this case is that she had asymptomatic infection, no symptoms at all of Zika, dengue, or chikungunya. So that shows us that even asymptomatic infections can be associated with malformations. Why that matters? Because only 1 in 5 Zika infections will have symptoms. So we have a visible problem, but a much larger invisible problem unfolding. And just yesterday, there is a new piece of research that came out from a group of researchers in Rio de Janeiro in Brazil. And they used human neural stem cells that they grew to closely mimic brain cells. They infected them with Zika virus, and they were able to show cell death and reduced growth. That's probably the closest step we have made to be able to show an effect of Zika on brain development. There is also a group looking to see if there are any vectors that can transmit Zika. I hope they don't find anything, because vector control is challenging as it is. Only with Aedes aegypti, we don't need another vector to interfere in this process, but I'll talk about vector control later.
Great. Okay. Ashish, you've evaluated the World Health Organization's response to Ebola. I'm wondering if you can tell us, what similarities and differences you see now with the response to Zika.
Sure. So obviously the Zika outbreak comes in the shadows of what happened with Ebola, and I think it's worth taking about 30 seconds and thinking about what we have learned from the Ebola crisis. So I think there is very little doubt that the world failed in its response to Ebola. I think by lots of estimates, probably 90% of the deaths that occurred in West Africa could have been prevented if the system we had in place to respond to diseases like Ebola had worked the way they were supposed to. And the failures were multiple, and certainly they were failures both at the local country level as well as at the international level. The response to Zika has been better. I mean, it certainly has been much better by the individual countries. It's been much better by PAHO, the regional agency, and I think Niels will talk more about this, and by WHO, declaring relatively early on the public health emergency of international concern. That better response, I think, has to be thought about in the context of three facts, right? The first is that Zika happened in the spotlight of Ebola. The world was watching. The chances that there was going to be a delay this time, I think, just weren't very high. And in fact, some people have asked, did they go too fast? I don't think so, but that's a reasonable concern. But it happened under this spotlight. The second, and I think, and we'll hear more about this from Niels, but it happened in Brazil, which is a country that has a much better public health system. And then both Ebola and Zika are diseases that are not particularly contagious. If you think about it, Ebola is a caregiver's disease. You actually have to have contact with people who are very sick. Zika obviously is primarily transmitted through mosquitoes, though we now know it can also be through blood transfusions and sexual activity. And so in my mind, when I take a step back, I think the big question in front of us is what happens when the spotlight is off, because there will come a time when not everybody's paying attention. And we have a disease that hits a country with poor infrastructure, poor health system, and is highly contagious. How ready are we for that scenario? That is a scenario we will live through at some point. Hopefully not anytime soon, and hopefully we'll have enough time to prepare for that, and I think we'll come back to that. But that's the big question. I think we've seen a better response for WHO, but it does not give me confidence that we are where we need to be.
Niels, you served on the executive board of the World Health Organization. Can you tell us how Zika and the response to Zika sort of fits into global health priorities and the global health agenda?
Yeah, and let me just start by echoing Ashish. In this instance, important pieces of the global public health system actually have worked pretty well. And it's really in marked contrast to the experience with Ebola. I'll come back to that. But the other important issue is that the spread of Zika and the associated microcephalus clearly once again demonstrate that we need to pay attention to the whole system and not just to individual pieces of the system. And finally, the system is not just a biomedical system, but it's also social, economic, and political. And let me briefly talk about those things. In terms of things working, we're very fortunate that Zika emerged in a country that has a very robust public health system. Fiocruz, their public health institute, is one of the world's leading public health institutions. The fact that this emerged in 2015 and was identified in spite of the delay of pregnancy before the end of the calendar year is a really marked contrast to the experience with Ebola in West Africa. And for that, the Brazilians really need to be recognized and lauded. The Pan American Health Organization, the regional arm of WHO, has been on the case and responsive, as has very much CDC. And the World Health Organization took quick action in terms of declaring a public health emergency of international concern with respect to the microcephaly. And were, I think, appropriately careful about the causal linkage between the virus and microcephaly, although increasingly it really appears that those things are deeply intertwined. So those things worked, and then on top of that, the fact that we had a system in place to start responding internationally through the Global Health Security Agenda that was launched by the Obama administration now nearly 2 years ago. This has sort of put us in a pre-positioned spot, and yet we see that Zika is spreading rapidly. We see multiple thousands of cases of microcephaly. We're seeing them now in some other countries in addition to Brazil. And what really becomes clear is that the public health system is not just a matter of getting vaccines in place or diagnostics in place. The people who have been most deeply affected initially are the poor, the disenfranchised, people living in slums. This is the area where you have breeding grounds for the Aedes aegypti mosquito, where environmental controls have actually gone down over the past 20 years. Aedes was almost eliminated in the Western Hemisphere through the end of the 1990s and has come roaring back because we stopped paying attention to this, and particularly stopped paying attention to it in low-income areas. So it is a matter of social and economic justice which impacts on public health for all of us. I think most troubling in terms of the dynamics that we're seeing here is the issue of who is most profoundly impacted, which is mothers and their children. We've seen that the Minister of Health of El Salvador has recommended that no woman get pregnant until 2018. And this is in the context of some very disturbing realities on sexual and reproductive health and rights throughout Latin America and the world, in fact, where most of these women don't have good access to contraceptives. They don't have control over, there's a lot of sexual violence, and certainly they don't get to say no. And they don't even have good access to services that they might be able to use to prevent pregnancies. And in no instance, certainly in El Salvador, where abortion is totally against the law, could they take action if they learn that they're pregnant and have an infection. This is, I think, at best naive and at worst deeply cynical. If we're not going to deal with a disease that takes an enormous human toll, in the US it's estimated that if you have a child born with microcephaly, the lifetime costs of that are $1 million. Obviously the costs are less in low-income countries. The proportional costs are vastly higher. And we have to recognize that unless we deal with this at all levels of the system, we're simply turning the problem over to those with the least power to do anything about it. So I think this is a reminder of a statement that was made by Rudolf Virchow over 150 years ago, that public health and medicine are social interventions, and politics are public health in the most profound sense. We have to deal with this at all levels of the system, internationally as well as domestically, if we're going to really have an impact. And I think maybe nature is trying to give us a warning. It's time to do something.
You know, and thank you for that nice introduction. I mean, we are now going to be taking a look at a video of a woman in Brazil. And, you know, unfortunately, diseases like this, infectious diseases, often do impact the most people who have the least access to care and the least ability and fewest resources. Here's a Reuters video of a woman who is taking a long journey to get her baby with microcephaly some care. So let's take a look.
At a remote farmhouse in rural Brazil, Miriam Araújo wakes up before dawn to start her long trek to a city hospital, where her son will receive treatment for microcephaly. Reuters correspondent Stephen Eisenhammer joined them on the journey.
In front of us is the car from the city hall. It is taking Miriam and her son Lucas to Campina Grande for physiotherapy. We've been up since 3 in the morning. It's now 5:30, it's getting light. And we're still on the road, we're still driving. Hopefully we'll arrive in the next hour or so and then it's a full day of physiotherapy before Miriam gets back, sometimes as late as 8 in the evening. And she's got to do that 2 or 3 times a week. So it's really, really eats into her time.
Araújo is one of a growing number of women in Brazil's poor and isolated northeast region struggling with babies born with microcephaly, believed to be linked to the mosquito-borne Zika virus. The physiotherapy is vital for her son, 5-month-old Lucas, born with an abnormally small head, brain damage, and motor control issues. Araújo hopes the government will also open more treatment centers closer to home so that little Lucas doesn't have to make this tough journey.
As you can see, this virus is really striking some of the most vulnerable people, and it exposes the problems that exist when people have a lack of access to needed care. But in some ways, it was lucky that Brazil was a country where this outbreak really made an impact. And I'd like Nils to tell us a little more about that.
Well, the public health system in Brazil is really quite robust, and the Brazilian government has taken this on as a major responsibility. In fact, Brazilian experts have helped work in other countries, in Africa in particular, to help them build their systems. The U.S., during my time at HHS, looked at Brazil as very much a partner, not a recipient, but really an equal partner in terms of public health activities and programs. And again, I would note that the Fiocruz, the Fundación Oswaldo Cruz, is a really important global partner in many of the research and epidemiological investigations that take place. So this is certainly a strength, and they had good surveillance systems. They picked this up as early as one might possibly hope that they could. But I think, as I said before, that's only the start. That allows you to get a little bit of a start on your response, but it's also highlighted many of the gaps in the system.
The United States is not going to be immune to this outbreak, and I'd like Dr. Fauci to tell us what's anticipated for the United States as we face the coming threat of the mosquito and Zika.
Well, we certainly will have many more imported cases. We already have well over 100 imported cases right now. We have local transmission in Puerto Rico and in the Virgin Islands and American Samoa. What likely will happen is that we will see something similar to what we have seen in the past with dengue and with chikungunya. When you have the amount of imported cases that we almost certainly will see, I think people don't fully appreciate that on any given year there's between 30 and 40 million people go back and forth between the United States and South America, Central America, and the Caribbean. Among those are an awful lot of pregnant women, for example, but there are all people who are not pregnant. They just keep coming back and forth. So we're going to have more and more imported cases. When that happens, you almost inevitably, particularly in the part of our country, in the southeastern part, in the Gulf Coast, Texas, Florida, and others, we will see local transmitted cases. If it acts like dengue and chikungunya in the past, those local outbreaks will be well controlled by an aggressive mosquito control program, because we have seen both. We've seen dengue outbreaks both in Texas and in Florida, and we've seen a chikungunya local outbreak in Florida, all of which were suppressed. We can't say for sure that we're not going to have a major outbreak in the United States. I do not think we will, but we will be prepared for it anyway. But I don't think, given the conditions that we have in this country, that we're not going to see a massive outbreak. But I think the domestic local outbreaks are going to cause a great deal of concern. And I think we need to be prepared to be very, very vigorous in getting correct information out to the public. Because as we know, and I was part of that need to do that and communicate, in the Ebola time, something like 2 nurses who got infected in a hospital in Texas created an enormous panic in the United States. So we need to be prepared to continue to give out correct and measured information to people.
Thank you. Dr. Jia, I'd like to know a little bit more about how an outbreak like this, affects global infrastructure, health infrastructure, and, what is needed, in response to this and other outbreaks.
Yeah. So, Tony brought up the 30 to 40 million people traveling back and forth. And it's a very good reminder of the world we live in, right? A deeply interconnected, interdependent world where, unfortunately, you cannot build walls and keep people out and think that you can protect yourself. It's beyond being, I think, a morally repugnant strategy. It is completely ineffective. And fundamentally, we are only as safe as the weakest health systems out there, right? If we are going to live in an interdependent world, which we live in, having health systems around the world that are, and I'll talk about what I mean by being weak, but these health systems pose a threat certainly for their own people and really for the whole world. And as Niels has said, Brazil is actually quite far along and has a lot of basic infrastructure that I think is critical. I think President Obama has been very clear through the Global Health Security Agenda, which has been mentioned, that there is an interest in the part of the U.S. government to invest in health systems. Countries need basic surveillance systems. They need a public health infrastructure that can respond to diseases. The lack of that in West Africa surely delayed us by several months, if not longer. And actually, even once it became recognized, I think the lack of the public health infrastructure slowed down our response. So what do we need to do? I think we need to make global investments in these very basic fundamental things. We need to be able to mobilize external resources far more quickly than we've been able to. I think we're going to talk a little bit more about this, but we need a strategy for generating and sharing of knowledge. So a new disease will pop up that we don't know much about. How quickly can we develop a vaccine? How do we deal with treatment? How do we begin to start doing studies? What's our general strategy on that? And how do we do that effectively in the middle of a pandemic? We have not figured all that out yet. I think we learned a lot from Ebola. I think we're learning more from Zika. But again, I worry about that disease outbreak where you have a highly contagious, potentially fatal disease, and we need a system to respond to that, and I think we need to make investments now. And again, I've been very happy to see how much of a focus there has been on part of the U.S. government. We need a lot of focus from all the other high-income countries as well in making this a priority.
Dr. Fauci, I wonder if you might weigh on this topic too.
It's extremely important. One of the things that we keep getting asked, and I had to testify 6 times in the last 2 weeks in front of the congressional committees about this, is why weren't you prepared for this, like on a dime to move? And you can make a list of diseases and say, well, let me develop countermeasures or what have you for these diseases, which there's some merit, and I think modest merit at best to that. But then there's the issue of how do you have a system in place, and it was mentioned a couple of times, the Global Health Security Agenda and Initiative, that you have to have the infrastructure in place to respond to anything. Because if I was to make a list a year and a half ago of the 9 or 10 vaccines that I would want to make, Zika wouldn't even be in the same galaxy for that list. And if 30 plus years ago I was asked to make a list, HIV/AIDS would not have been on that. Right. So it's the same kind of thing that Ashish was just saying and that Niels was saying. We need to have that ongoing because it's almost a trite saying now that we live in a global community, but we really do live in a global community. And I like the comment that you made about keeping people out of borders, because I got asked that question multiple times during the congressional hearing. It was really very interesting when you have 30 or 40 million people flying in and out and you're worrying about somebody coming across the border. I got a kick out of that one.
Dr. Fauci, I wonder if you might tell us a little bit about where we stand with diagnostics, vaccines, and treatments for this for Zika virus.
Okay, well, I'll do that briefly. For diagnostics, I think people need to understand the difference between diagnosing the infection and diagnosing whether you were infected. Diagnosing the infection is with a PCR reaction. That's easy, it's cheap, a lot of people can do it, you don't need anything special. Virtually any medical center can do that. The trouble is, or the good news is, that the virus doesn't stay in your body very long. It stays in for about a week or the most. The question people ask is, was I infected? And right now, the test that we have to determine if you were recently infected, which is an IgM test, is a good test, except that it has a considerable degree of cross-reactivity with other infections, particularly other flaviviruses like dengue. So if you're in an area where there's no chance you've been exposed to dengue, it's a pretty easy test to tell you've been infected. But if you live in Brazil, where most of the population's been exposed to dengue, there's a lot of cross-reactivity. So from there, you then go to a test that's a plaque reduction neutralizing test. That's a neutralizing test that is specific for Zika. Only a few centers, including the CDC, can do that. What the CDC is doing now is two things. They're shipping out a lot of tests to state and local authorities to be able to do it so they don't have to send it someplace. At the same time as that, we're working on that diagnostic that I told you about that would be highly sensitive and specific. That's not rocket science. I think we're going to get there in a few months to be able to do that. That's not a big deal. Vaccine is another interesting thing. I can tell you exactly where we are. We have about 4 or 5 candidates that soon will be mobilizing. The one that's probably temporally ahead of the others is a vaccine platform that we successfully did for West Nile some time ago. And it's a DNA plasmid in which we stuck in the gene for West Nile. We did a phase 1. It was safe. It induced a good response. Great. What we're doing now is just pulling out that insert and sticking in a Zika insert. And I just got an email right as we were sitting here that we've now got that into the pilot plant to start to make for preclinical tox studies and enough to do a phase 1 trial. That will start at the end of the summer, early October, take about 4 to 5 months to show if in fact it's safe and it induces a good response. By the end of 2016, early 2017, we'll be able to know if it is. If it is, then you go into advanced trial. And here's the thing that people don't understand, because it was an interesting thing with Ebola. If the epidemic is still raging, be it in Brazil or Colombia or the Caribbean, it's going to be relatively easy to show whether that's effective. So if you have thousands and thousands of cases, in a period of 8 to 10 months, you'll know whether it's effective. And then the regulatory authorities, be they in Brazil or the United States, can make a determination whether they're going to approve it. If the cases go way down, it may take a few years to show if it's effective. This is what happened to us with Ebola in West Africa. We had a vaccine, but by the time the vaccine was mobilized, luckily for the countries, the cases went down. Finally, therapeutics. We're working on screening a bunch of therapeutics. But when you have an acute infection like this, in which, as Marcia mentioned, cases, you don't even know if you're infected or not, therapeutics are not the top-of-the-line countermeasure. Yeah. The top-of-the-line countermeasure is a vaccine for the people and mosquito control for the environment.
Thank you. And Marcia, I'd like to see if you have some comments on that as well.
Yeah, so I second the last sentence that Dr. Fauci said. I totally agree with that. But I would add one thing to this is, if we can get a test that would be part of a protocol in antenatal care, like we have tests for toxoplasmosis, hepatitis, HIV, and so on, the question is, what's going to be the protocol if the test is positive? What's going to be the protocol if the test is positive and the woman has an ultrasound showing malformation? And the issue here is, first of all, we don't know what's the risk that a malformation is going to happen, depending on an infection at a certain point in time in the gestational period. We don't know those risks. But if we do reach a point that we have that test in the antenatal care, and we do have a test that is positive, and we do have an ultrasound with a problem, What are we going to do? What is the protocol? If you look at most of the countries being impacted, terminating the pregnancy is not legal. So it would be fantastic to get those tests, but we have to start thinking now what are going to be the legal mechanisms to establish a protocol to actually take action, because right now I don't know what action we would be able to take.
You know, I'm wondering if you can just say a little bit more about the research and what questions we still have. What do we need to know?
Well, we still have a lot that we need to know, and I was talking to some folks before. I always feel that we answer one question and we get two new ones after that. But I think we still need a lot on the clinical side, on the immunology side. But I want to highlight two things that we should be doing. I think we need a very comprehensive, retrospective epidemiological investigation. We have the CSI. I think we need the ESI, epidemiological scene investigation. Because if you look at a country like Brazil, why all the microcephaly is mostly in the Northeast? Why do we have the smallest state in Brazil in the Northeast with several cases of Zika, no microcephaly? Why mostly in one state in the Northeast, Pernambuco? Why Rio de Janeiro, that has tons of cases of dengue and Zika, we have 2 cases of microcephaly? So there's some issue going on that probably is right in front of our faces, but we have no idea what it is. And maybe this kind of epidemiological investigation could help. And the second thing that there's some happening, but not that much. I think we need cohort studies to follow those kids that were born with the microcephaly, but also kids that were born without microcephaly, yes, but from mothers that had a Zika infection. And we need to monitor their motor development and cognitive development, because it's almost a done deal that there are going to be future complications, and we should be prepared to respond. And in fact, there is one complication happening right now, which is a major increase in epilepsy among those kids. So if we don't monitor them and we don't have cohort studies, we're not going to be prepared to respond fast.
Great, thank you. And we've touched on this a little bit, but I wonder, Dr. Dallaire, if you could talk a little bit more about global governance issues and how that might, help guide some of the studies that need to be done, et cetera.
Well, and I think one of the keys here, and I think everybody has pointed it out one way or another, is the importance of long-term thinking and the importance of systems thinking. Sometimes, and I'm deeply sympathetic to Tony and his multiple congressional hearings, sometimes I feel like when you're dealing with politicians, it's like yelling squirrel to a golden retriever. It's easily distracted to the latest thing, but the importance here, I think, is recognizing that we need a global system to prevent, detect, and respond. We don't know what the next big thing is going to be. We know what this one is. We know what the last one was. There's going to be another emerging infection, and there'll be one after that and one after that. That is the nature of nature. And so unless we get really serious about building this and investing in it for the long term, not just sort of what's our response to Zika, but what's our long-term plan for global health security and for emerging and re-emerging diseases, we're always going to be behind the curve. It's very clear, as Ashish said, that it's the countries with the weakest systems that are, in a sense, the places where these things are going to happen. Mm-hmm. And beyond that, it's the poorest communities in those countries with the lowest level of services and access that are going to be the breeding grounds. As Tony says, you can't put a wall up everywhere. In fact, with Zika and other mosquito-borne diseases, they'll fly over the wall anyway. So it really doesn't matter. I think one of the big concerns I have when you talk about mosquitoes, we're a few weeks away from an active mosquito season in the southern part of the U.S. Mm-hmm. Right now it's Aedes aegypti, which has a relatively limited range in the deep south. But we're waiting to see if this will spread now to the so-called tiger mosquito, which has a much larger range in the U.S. and around the world. So we can expect to see a lot more cases, and I hope Tony's right, that it'll only be in limited areas and that we'll be able to deal with it quickly. But that's going to raise enormous public pressure to do something about this. And I really do feel that the recent request from the administration for $1.9 billion additional funding to deal with Zika is very important. It's not sort of money that's being used for just one problem, but also to help build the response capability. And finally, WHO still has a lot of rebuilding to do. It's, I think, has conducted itself responsibly and thoughtfully in this instance, but with strong support from the region, from the Americas region, and from the US and Brazil. But I think there's a long distance to go in terms of strengthening and holding WHO accountable to really serving as the protector of global health.
You know, I want to throw this back to Dr. Fauci. Can you say a little bit more about the need for, you know, an integrated international health system?
It's absolutely essential because for everything everyone on the panel has been saying, it has to be integrated, and that was the purpose of the global health security agenda, is to have an integrated connection. And you know, the metaphor is so true that the chain is essentially dominated by that weakest link, and all you need is a lack of ability to integrate and communicate, and you could have a disaster. And we have seen that in situations where there have been outbreaks that have taken a while before they've been recognized. And I think our very sad experience with Ebola is so fresh in our memory. If you think about not only realizing you were dealing with a problem in December of 2013 instead of waiting until March of 2014 and the summer of 2014, what could have been done, there could have been a lot of lives saved. And that's very, very sad. Very sad.
You know, we've touched on the issue of women's health and how, you know, this exposes some of the need for human rights. We're closing in on, you know, we've got about 15 minutes left, but I do, you know, I want to throw to the panel, I mean, can you just, you know, sort of illustrate for us some of the issues that this outbreak brings up? And maybe Dr. Castro, you could start.
Sure. So briefly, so you take most of the countries, Brazil included, there is a significant percentage of the pregnancies that are unwanted. And that shows the gap that we have in terms of access to contraception. And we're talking about Brazil that has a below replacement fertility even across a socioeconomic level. So all incomes levels have experienced declining fertility. So one barrier is this: you do have a lot of poor women that don't have the adequate access to contraception. The second thing is, there has been a lot of discussion in Brazil back in January, is that all the campaigns, all the messages were missing the 3 word, men. It was never in the message. And they're trying to make it a little bit better now, but there was a lot of controversy in the beginning because of that.
Wow. Okay. All right. Anybody else on the panel?
Yeah. I mean, I've often heard, I've been in this arena for a while, and I've often heard people say, well, we care about epidemics and pandemics, but why should we worry about family planning and sexual and reproductive health and rights? This makes it very clear how deeply tied together they are. And I'm sure this is just the tip of the iceberg in terms of infections that could be passed and are being passed sexually without our awareness. It is profoundly disheartening to see that somewhere between a third and a half of the women in the Americas, one of the best off regions of the world, still do not have effective, reliable access to contraception, to family planning. Now, that's not the answer to all of our problems, but certainly people should be able to make that decision. Women should be able to make those decisions themselves, whether they want to get pregnant. And even places where you've got family planning in place and access to contraceptives, we have these enormous levels of stockouts of contraceptives. So if you've got it this month and not next month, that's kind of a problem, particularly when you're dealing with a disease like Zika. And then last, and certainly not least, is the issue of the criminalization of abortion. We know that abortion takes place throughout the world, whether it's legal or not. It just takes place in unsanitary and dangerous conditions in the places where it's particularly illegal. I think it's safe to assume that there will be an upsurge in illegal abortions, back alley abortions, in Latin America as women worry about this. We have some responsibilities to protect them. When you look at countries that have absolutely no exception to a ban on abortion, such as El Salvador, not for the life and health of the mother, no exceptions whatsoever. And even if you do have it for an exception for the life and health of the mother, it's not the mother who's immediately at risk here. It's the fetus that will be born with microcephaly and bring this enormous burden on the woman, the family, and society afterwards. We have to look at this from a human perspective and from a social perspective and from a political perspective, and these are tough issues to deal with.
Thank you so much. I want to give you and the audience and our online audience an opportunity to talk, but I'd first like to acknowledge we have a guest in our audience, Dr. Leonard Marcus. Dr. Marcus is co-director of the National Preparedness Leadership Initiative at Harvard. I'm wondering, I understand you have some questions or comments. I'd love for you to weigh in. We've got a mic for you.
Thank you very much. Dr. Fauci, we here at the NPLI study leaders during times of emergency and find that the better they're able to lead, interact with one another, communicate, anticipate, the better the response and the effect during an emergency. There were bumps in the road in the leadership of the domestic Ebola response. An Ebola czar was appointed. How are leaders taking those leadership lessons from the domestic response and then applying them in looking forward to the response regarding Zika here in the United States?
Yeah, we have a rather well-coordinated and interdigitation both within the department, HHS, which is the lead agency, but also USAID and state is also very much involved. We are in communication constantly and reporting back and forth among ourselves, with the secretary being the lead person through the assistant secretary for preparedness and response, whose major responsibility is to coordinate what we do. And myself as the NIH component, together with Tom Frieden as the CDC component, are literally in touch with each other every single day, and including with the White House. So this is a very well coordinated effort. And that's really quite smooth, I must say. I mean, I think when we started off with the Ebola, when we finally got Ron Klain in as the czar, because there were multiple more agencies involved. There was defense was more heavily involved. Right now, it's really much more compact between HHS, state, and USAID, and it's working very smoothly. Communication, I think, is really also very good. Tom Frieden and I and Secretary Burwell and others have been not only in the congressional hearings, but have been regularly briefing the leadership of the House and the Senate. When I say regularly, I mean like every day. So it's I think we're in pretty good shape when it comes to that right now.
Great. And I know that we have some questions from our online viewers and listeners, and so I'd like to take a question, at least one or two from the online community.
Thanks, Julie. We have a lot of questions coming in online, a lot, so we're just going to have time for a few. This is from Georgia Argentini, an MD working and living in Brazil in Rio. Given the high numbers of cases of dengue in the past year in Brazil, mostly in the same area northeast of the country, why did WHO declare an emergency for Zika and not for the 200% incrementation of dengue cases? And is it possible that a previous or concurrent dengue infection in pregnant women caused the microcephaly if infected by Zika during pregnancy? Wow. This is about the concurrent possibility of infection.
Who would like to take that one?
So maybe you can address the first, I can address the second.
Well, the first issue, the declaration of a public health emergency of international concern is different from a declaration of an outbreak or an epidemic. And so what triggered the declaration from WHO was the severity and the potential impact on not only a national level but beyond national borders of microcephaly. Their declaration was about microcephaly, not about Zika, even though Zika was causally associated but not yet proven. So the fact that you have X number of cases is not the thing that causes the declaration. On the other hand, the government of Brazil and the Pan American Health Organization and WHO do have a very active role in dealing with outbreaks such as dengue and dengue hemorrhagic fever.
Great.
Yeah, and regarding the second, that's one of the questions that we don't have answers for. I personally think there is a possibility that this is true. There could be factors that make a Zika infection more severe. Dengue could be one of them, could be something else. That's yet to be answered.
You know, I want to throw that to Dr. Fauci too. Is a prior dengue or chikungunya infection amplifying the Zika virus in some way?
We don't know the answer to that question, but as Marcia said, it's a very important question. We do know that if you have one type of dengue recover and then get infected with another type of dengue, you could have the paradoxical effect of enhancement of the disease. But the relationship between the prior exposure to other infections and what it means for Zika still is something that has to be part of both the cohort study and case control studies, as was mentioned by members of the panel.
Okay, great. And one more question from
Great,
online?
thank you. Yes, let's do one more. This is from Shreya Tapaswi from India. If Aedes mosquito is the vector of the Zika virus, could you speculate which organism can be the possible reservoir of the virus? Between two successive outbreaks, where does this virus go to hiding? Are tropical and equatorial areas more prone to this virus?
There is no reservoir. It's just between the mosquitoes and the humans.
It's just, yes, okay. So I think we've gotten a couple questions about this, and there's some confusion about that.
No, there's no reservoir.
Okay,
all
great,
right.
thank you.
And maybe one from our audience? There's a mic coming to you.
Hi, thank you so much. My name is Ishan Desai. I work with Partners in Health, a health and social justice nonprofit. I want to thank the panel for your comments on kind of highlighting the disproportionately high impact that Zika is having and is going to have on people living in poverty and those marginalized by other social forces, including especially gender inequity in this case. That said, I think that, of course, is the only kind of the first half of the diagnosis. The other part of the exercise is what can we do about it in places of poverty. In Haiti, for example, where PIH works, there's little in the way of laboratory or diagnostic capacity of child development services, of family planning. So what kind of steps would you advocate for settings of poverty, and what kind of interventions can be taken? Thank you.
Would somebody like to address that?
Let me start, and then we can move on. And that's a question that could take up the next week in responding to us, so I'm going to have to just do shorthand. We've seen that over the past 15 years, or close to 20 years now, the U.S. has pulled back enormously from engagement in development assistance in Latin America. That's been driven by budget realities, as the amount of foreign aid to international development assistance has been either capped or absolutely decreased, and tough decisions have had to be made. We're hugely underinvesting. And to really address these kinds of issues, the U.S. ought to be far more engaged internationally, particularly in communities, low-income communities, not just in the very, very poorest countries, but recognizing that there are low-income communities in middle-income countries as well that need attention. The U.S. can't do all of this by itself. Clearly, part of it is the kind of political and diplomatic pressure that's required to engage countries in looking at these issues among their own people. And then last but certainly not least, you need to practice what you preach. And here in the U.S., there are many populations, we've seen it in Flint, Michigan, and other places, where the poor are sort of left to their own devices. And this, I think, is a very important issue in terms of U.S. providing strong leadership at home in order to encourage things abroad.
Thank you.
So, and let me build on that. While I completely agree with Niels, excuse me, that there has been this pullback, there are a few places where the U.S. has been more engaged over the last 10 years. If you look at PEPFAR, if you look at our efforts on malaria, And the lessons from that are couplefold, right? On one hand, we can do enormous good when we're focused. And there are really important payoffs, not just for those societies, but in terms of building stability in those societies, thinking about how those societies perceive us. So even if you look at this from sort of a diplomacy and security agenda perspective, there is, I think, real value beyond the moral argument, with which I agree, real value for the American people to be much more engaged in these issues. So for whatever kind of gets you to the table, I think I'm going to echo Neil's point that that we have to be engaged in these things far more effectively, with more resources and much greater engagement than we have been.
Okay, now we've asked our panel to quickly, in about 30 seconds each, make a recommendation to policymakers on this important problem of Zika. So we'll go this way, and then we'll ask Dr. Fauci too.
Okay, so I'm going to get vector control. Cities are growing fast. Without infrastructure, you create the safe haven for Aedes aegypti. I cannot imagine how vector control is going to succeed if we do not provide sanitation, piped water, and regular waste collection without a collaboration between different sectors of the government, because it can't be health to do all of this, and without collaborations between the government and the industry. If we don't do this, we're going to keep wasting a huge amount of money without effective results. So the time now, and the clock is ticking.
Okay.
Great. And I'm going to say that we need to take this opportunity. I mean, we are very good at putting out fires. Putting out fires when they occur is very important, but we have to take a long-term perspective and use this as an opportunity to start making the kinds of investments in health systems, in surveillance systems, public health responses around the globe. Again, both out of a sense of, I think, a moral duty, but also a sense of enlightened self-interest. We are not going to make the American people safe unless we have a global system that works.
Nils?
If we undertake public health response piecemeal in unconnected pieces and without consideration of social and economic justice and rights, we will fail to protect those most at risk, and importantly for us here in this country, we will fail to protect ourselves. We have to look at this from the broad perspective, and that's the only way we'll be safe.
And Tony, who makes this case all the time, what's your one policy recommendation?
Well, diseases have emerged throughout the history of civilization. They're emerging right now, and they will continue to emerge. And I think we have to realize that as difficult as it is to argue for support for something that hasn't happened yet, I think we've learned over the last few years that absolutely is essential from a global public health standpoint, as well as from a research and healthcare infrastructure standpoint. How many times do we have to see this happening before we realize that it will happen again?
Fantastic. All right. Well, we've had far more questions, and I'm so sorry that the audience here didn't have too much opportunity to ask your questions, but I encourage you all to continue the conversation on the forum's website, and the address is forumhsph.org. I'm sure you know it better than I do. Thank you so much for listening in. I appreciate it.